to the cloud.
Wonderful. Good afternoon, everyone. Thank you so much for taking time out of your busy schedules and day and away from clients to be with us today. This is our, I don't know, fifth or sixth clinical educator virtual engagement event. It's on group models of supervision for SLP and audiology clinical educators, hosted by the academic coordinators of clinical education or the ACE team or clinical coordinators, and myself and my lovely colleague Evan are the facilitators today. We also have other members of our ACE team with us. I see Lisa left and I see Kate Davies. So thank you, ACE team, for your support. All right. I'd like to start with some land acknowledgements. UBC's Point Grey campus is located on the traditional, ancestral, and unceded territory of the Musqueam people. The land it is situated on has always been a place of learning for the Musqueam people who for millennia have passed on their culture, history, and traditions from one generation to the next. I'd also like to acknowledge and respect the Lekwungen, the Songhees, and Esquimalt peoples on whose territory the Vancouver Island Speech Language Pathology Program is located, and the Lekwungen and Wasanich peoples whose historical relationships with the land continue to this day. For those that aren't familiar with our new Victoria campus, the picture in the top left-hand right of your screen, that's our Victoria program. And the right-hand screen is the Vancouver campus. All right, so we have some panelists that I will introduce you to quite quickly. We'll go through some of the questions that you have given us. So thank you so much for taking the time to give us those questions. We really want to tailor this event for the people that attend. So hopefully we'll answer all of the questions that we received if you did fill out the RSVP. There will be time at the end and during, we do want to make it as interactive as possible. So feel free to raise your hand or pop your questions into the chat. Evan will be monitoring the chat function. And if you do have any other questions at the end, feel free to ask us. And then we'll end with a few housekeeping things. I've already said that. Raise your name. Oh, so yeah, please enter your first and your last name as your Zoom name if you can. And yeah, I've said all that already. Getting ahead of myself. All right, so I'd like to introduce our panelists for today. They have taken students for a 2-on-1 group model of learning, and they are here to share their experiences and their knowledge and skills with us. For audiology, we have Stephanie Kaur. She works at Vancouver General Hospital, and she's been the clinic coordinator for the SAS in-house audiology clinic. Unfortunately, she has a student right now and wasn't able to take time away to be here during this event, but she gave me a very succinct and thorough information page that I will also send to Jamie, because at the end of this event, we're going to post our recording, the PowerPoint slides, and the document that Stephanie has made just specifically for audiology clinical educators. I've made it into a document that was so well written. So thank you, Stephanie, for the time that you put into that. I'd like to introduce our panelists today from Speech Language Pathology, Kayla Patterson. And Kayla, can you help me pronounce the hospital that you work at right now in Powell River? I don't want to get it wrong.
Kithett General Hospital.
Thank you. Ivana, and I'm sorry, I should have been a bit more prepared. How do I pronounce your last name?
Pronounced Perpic.
Perfect, thank you. From the BC Center for Ability. I'm Colleen Leung from Queen's Park Care Center. They'll introduce themselves in a little bit more detail after I stop talking. So here are questions. I'm going to show all those questions. I know it's a lot, but I will. I have the questions written down, so I'll take the questions away once we've gone through some introductions from our panelists, and I'll moderate the questions, and Evan will moderate the chat. Is there anything, Evan, that I've missed before we get started?
No, I think we're good.
Okay, so to all of our panelists, what is your experience with group models, and what does a group model look like in your setting? Who's, yeah,
I can go first.
yeah.
So I'm a speech therapist who works in early intervention at the BC Centre for Ability, and the population consists of kids under the age of 5 with complex diagnoses, and they usually require really interdisciplinary teams. As a result of long wait lists and the hope to bring in more students and hopefully support multiple different people at the same time, we've been piloting the SLP student-led clinic, which is really driven by students and it's for students. And the model is built around having 2 students at one time to be part of the SLC each placement block. So clients are invited to participate in an intensive block of therapy, which is really run by the students who plan each session under my supervision. So that's kind of the way it works here at the CFA.
Great, thank you, Ivana. I'm just writing our order. So we'll have Ivana, Kayla, and then Colleen, if all the panelists sort of answer one question at the same time.
All right. So I'm a speech language pathologist at Educator General Hospital, which covers, my role covers the whole Northern Sunshine Coast for acute care, home health, as well as outpatients for the adult and geriatric population. My previous experience taking 2 students was back when I worked with Alberta Health Services, and I took 2-student model for quite a few years, but more in a rehabilitation outpatient capacity. So when this opportunity came up with UBC, I thought it'd be really great to just see how it could potentially be facilitated in a different type of model with different caseloads.
Okay, I'll go next. So I'm Colleen. I work at Queen's Park on the inpatient stroke unit. So I see patients with a range of communication and swallowing disorders. My first 2-to-1 placement was last summer. It was a little bit different in that I had one student full-time that was with me Monday to Friday, and then the other student was with me part-time, shared with another colleague. So that second student was with me Mondays and Fridays.
Wonderful. Thank you, everyone. And thank you again to the panelists for being here to share your experiences. So we'll go on to question number 2. I'm going to also pop it in the chat. So how does the clinical educator effectively balance time to support 2 students?
Okay, so I'll take this one. So prior to the start of the placement, I did meet with my 2 students online to discuss their personal goals, learning styles, and expectations of the placement. I think this just kind of like helped me mentally prepare the thought of taking 2 students. And then I did have meetings at the start of the week to plan sort of like a rough schedule for the students. I think this was really helpful in my case because I only had one of the students part-time and I wanted to make sure that both students got equal opportunities when they were both on site. And then I did also offer meetings at the end of the week, kind of more like check-in meetings to see how things were going. I think I was just really mindful of making sure that each student felt like they were getting enough feedback and hands-on practice. I did offer to the students whether they wanted it to be together or one-on-one, and they ended up picking it together. And then I found that they actually didn't need much check-in meetings as they settled into their caseload and got more confident and more comfortable as the placement went on. I know it kind of sounds like there's a lot of meetings at first, but it ended up being fairly quick, and in my case, they did fade out at the end. And I think having these meetings front-loaded helped my students feel supported at that time.
Thank you, Colleen. And we do have the panelists sort of choosing the questions that they wanted to talk to, but just as a reminder to all the other panelists, if you have other ideas or wanted to share your experiences for the same question, please feel free to jump in, and Evan as well too. All right. So question number 3, how can the clinical educator maintain motivation and engagement for both students when there are differences in the students' performance levels? Kayla.
So with my 2 students, right at the beginning, I had meetings with them to kind of get to know them individually, their past experiences, where they felt more confident within the populations that we were going to be serving and where they had more worries. The model I chose my students to be in is they were always paired, but one of the students was like a lead, like the lead student versus like sort of the support student. So when when somebody would identify something as more of a challenge, for example, one of my students previously worked as a SLPA, so they felt very confident with treatment, but not necessarily with assessment. So if an assessment example would come up, I would ensure the one that was less confident was the lead on that client. And then the other student who maybe felt more confident in that area was supporting them. So they could spend some really good time together working and problem solving and coming up with ideas that they felt good with, even before they came to me with it, which I think really helped build skills within before having to practice or bring it to me even. Where in the past, when I've had single students, they would often just ask me over and over again, like, tell me what to do, tell me what to do. But there was some really good problem solving that happened because they were both trying to sort of lift up each other's areas that they identified as more worrisome.
Thank you, Kayla, for sharing. Is there any, Colleen or Ivana, do you want to add anything to that? If not, question 4 does follow kind of closely to that one as well. It's related. So even though this one's yours. Question number 4, how does the clinical educator support two students who may have different learning styles, goals, or needs?
It does kind of follow perfectly. So the way that I try to think about it is that when we have two students with really different styles or different learning goals, maybe they're thinking about different careers that they want to head into, like private versus public practice. It's actually not so different from how we do this when an individual student comes. So making sure that we set aside time for an individual meeting with each student to really get to know them and get to have a sense of what their learning style is. Do they learn better from reading ahead of time or really getting into the material on the ground? Do they have a certain way that they like to get feedback or a different kind of learning style with the acknowledgement that everybody does it differently? And especially in a situation where you might have two students who have very, very different learning styles, it can actually be very interesting to have students see different ways of learning, because that's also the reality of what it'll be like on a team, is that you might have people on your team who have very different learning styles, and you're going to have to communicate so differently with different people. So it's giving them a bit of front loading in terms of what they might expect on the job. The other thing that I'm trying to really drive home for my students, especially when they're very different, and there's two of them in at once in the student-led clinic, is that the comparison is not to each other. I think it's very natural, especially for these students who really want to do a good job in their placement. And in this, I can relate. I think many of us can. We have a desire to do well, and we have a desire to excel in the placement. Sometimes it can be intimidating when there's two students in at once, and there might be this feeling of like, oh, are they doing better than me? I think my role in that has been making sure that I drive home that we're really comparing to a baseline set out by the ACC tool, based on the school standards of what performance is at each point, and reminding students like, hey, this is a sandbox for you to try things with a peer and to try things with a colleague, kind of, because that's how it's going to be. I'm not comparing you to each other. I'm comparing you to what you should be learning. So if they're right on track, I just make sure to remind them that they're right on track based on those benchmarks.
Wonderful. Thank you so much. That's so important. I think the point of not comparing the students together, but to, the competency-based assessment tool that we've rolled out as of last spring, the Canadian assessment of, what is it? ACC tool, Canadian Assessment of Clinical Competence. All right. I would like to pause there. So I know that we're just running through these questions. Are there any questions from any of our participants, any of the attendees? You can raise your hand and pop it into the chat as a reminder. All right, if not, we'll continue. Here's question number 5. How can the clinical educator ensure that each student is given equal opportunities to demonstrate their clinical learning and skills? So Colleen, we'll have you go first, and then Ivana.
Sure. So Ivana will talk about this too, but we both did similar things where I had one student be the lead student and another be an observer student, and I actually had the students switch. So first off, the previously led leader student would review kind of the things that they've been doing with the patient prior to the new lead student planning for the session. And then I like the idea of them switching roles because on my unit, there can be such a range of different kind of like treatment protocols and exercises. So I found that when we did switch the roles, it gave the students both opportunities to try a certain exercise or treatment protocol with the patient.
Totally. We do that too, where one student might be like the point person or lead, and they're in charge of what's happening and the decision making, and another person might be doing a more structured observation. For example, in my case, I often have the observer student do a bit of a systematic evaluation of like autism red flags, which is still a really useful, structured, direct time kind of assessment. The other thing that we're trying this time around, which the physio student-led clinic does really, really well, and I think is brilliant, is the idea of co-treating. So we're having two clients in at once, and then each student is responsible for one client. We thankfully have like the luxury of space. So we have a few big rooms at the CFA where we can do this. So not always totally possible in a smaller space. But we set up kind of two play areas in a bigger room, and one student's over here practicing with their client or doing their direct therapy over here, and the other client's on the other side of the room, and I'm kind of floating in between. This is really good for students who are really starting to get a sense of independence. And there's some extra benefits I'll talk about later for my caseload and for my organization, but it really lets both students get a hands-on experience. So both the lead and observer, as well as the co-treating, has been useful for the student-led clinic model.
Excellent. Thank you so much. All right. Question number 6. How and when does the clinical educator provide the students feedback? So this is everyone. Even we'll have you start, and then Kayla, and then Colleen.
Absolutely. I think that Kayla and Colleen and I will have similar ideas about how to provide feedback. It's such an important part of the process. Setting up meetings intermittently as much as you can during the placement is really, really important. And I think we talked about this previously too, where at first we would do really one-to-one feedback, and this is still really valuable. So the student feels like they're getting direct feedback for themselves. But when we start to chat about things in a group, what I've noticed at the student-led clinic is that one of the students might talk about the things they could have done better, but in the bigger group, not just one-on-one with me. And so it really leads to kind of a group feedback model. And Colleen, I think, will also talk about this too. The other thing that I like to do is to provide the written feedback in the moment, especially when there's two students and we're thinking about time. Written feedback for me is so important because my memory is good but short. And so if I write things down right away in a structured feedback form, like things that went really well, things to try for next time, and I can just give that. I'm like, okay, give this a read. Let's talk about it at the end of the day when we have time. It lets them think about it, and then we can have a meaningful discussion at the end of the day.
I'll just add a little bit about the written feedback. I think when I originally started to try to do written feedback, I tried to make it very like perfectionist and like thorough, and it became very unachievable very quickly. So sometimes my written feedback is extremely simple. Like sometimes I'm literally taking data in a session and then I put like a smiley face beside one and then like 3 words of how they met that goal through that point. And I think my students really appreciated that because then they could also use my note to kind of cross-check their data when they're doing their documentation after to see if they were like consistent with that aspect as well. So I really had to give up the perfection and the thoroughness of the writing and just make sure they had something. Otherwise, they wouldn't necessarily have anything to work off of and evolve with the next session they had.
Excellent. Thank you all so much. Oh, Colleen.
Yeah, I also do written feedback as well. I find that super helpful because also my memory is not that great. So I do try to block off some time after sessions to give the immediate feedback. And then I also encourage the student that's observing to give their peer-to-peer feedback if they have any. But sometimes things are can be quite rushed or we run out of time. So the weekly check-in meetings at the end of the week that I have, I would, if I can't get to feedback right away, then I might use that time to give that feedback. So having things written down is super helpful because sometimes it could be maybe a day or two later. So we can kind of look back on it together.
Excellent. And everyone has talked about written feedback. On our virtual, so I'm going to just sort of digress for a little bit, but it's very important. On our virtual community of practice, or our VCOP website, I popped the link into the chat there. We do have a continue, start, consider, discontinue clinical feedback form. It's a written feedback form that if you choose as a clinical educator to use it, please feel free. What I used to do when I was a clinical educator with students was I would just photocopy this form. I would leave the back blank, so I just like to provide lots of feedback, written feedback. So the back would be blank for me so that I could write whatever I thought was needed on the back, but just photocopy a whole bunch at the very start of the placement, put it in a little duotang or a binder, and then the student would have this package or this feedback when they left the placement. So it was theirs to keep when they left the placement. Also too, because we were very busy clinical educators, it would help my memory as well. And you could see the progress from the student, from week 1 all the way to the end of the placement for the final evaluation. So it really does also help me with the midterm and the final evaluations. So feel free to use that. It's free up on our website, and that's where
share as well, Cheryl, because Colleen was talking about peer-to-peer feedback. This is something that the students could also start completing. So not just a form for you, but if you wanted them to actually write something and have it in a bit more sort of a structure, that is something that you could consider as well, because I love that peer-to-peer part. They hate it, but I think it's a really, really important part of their development and that competency skill development piece. And I will just echo as well what Kayla has said about the shorthand. I have to apologize profusely to my students when I give them my written feedback because it is just a bunch of scribbles, but it makes sense once they're used to me after a while because they know what the various symbols or the arrows or the whatever it might be means. So yeah, I think letting go of that, as you say, exactly as you say, Kayla, letting go of that perfectionist piece that this has to be, a novel or something that's, very coherent. It just has to have notes so that you remember because it's always supplemented by the verbal feedback anyway.
Exactly. Thanks, Ben. Yes, mine always had like things scratched out, written out, or scribbled out for sure. Mine was definitely not perfect either. All right. So this is another all panelist question. Question number 7. What were some unanticipated benefits of supervising 2 students? We will have Eva start.
Totally. The model for student-led clinic was designed for a few reasons at the BC Center for Ability, originally in physio and now in SLP, which it's been spectacular for. The idea was to expose more students to pediatric practice in these niche areas of practice, like complex AAC, like eye gaze and switches, pediatric feeding, but also to support families on the wait list who have been waiting a long time and might benefit from an intensive block of therapy. The really nice thing that's come out of this for all of our student-led clinics at the BC Center for Ability is that families get a really enhanced waitlist experience. So they get a block or 2 of therapy while they wait. And the waitlist can be like 6 to 9 months or even longer, depending on the region of the BC CFA. So that's been really, really nice for families. Even if they still have to wait after that, they feel like, okay, I have a set of strategies that I can try. We received some support. From a recruitment point of view, the learning curve at the BCCFA for students is steep. It's just the nature of the placement location, but with opportunities like this to come in and do the work in an intensive way, students have felt really empowered. And I've had multiple students say, well, okay, if I decided to work here, I could do this. And I feel really strongly about this. So that feels good because I remember what it's like to be in that position. It's a lot to learn very quickly, just like any placement location, right? But that's been really special. And the other thing too that's been really nice when we do co-treatment together. So 2 students are working with 2 clients. Parents and families have actually connected this way and they've become friends. And so with children who have maybe the same complex diagnosis or similar needs, like maybe they both have feeding tubes or maybe they both have AAC as part of their treatment plan, the families are actually bonding and now booking sessions in a co-treatment way together going forward, which is really, really sweet and has been a really meaningful benefit. And that's only possible because we have 2 students in at once. So that's been really special.
Thank you so much for sharing that. That's so inspiring. Kayla.
So some of the things that I was able to do, which being one SLP across 3 different programs at a rural site, was I was able to actually provide some treatment for people in acute care with aphasia. which is often extremely limited after stroke. And I can think of one individual who, because the students were able to work with him and really do some individualized treatment resources that really pulled out the competencies he had, he qualified to go to Holy Family. And actually get a block of inpatient treatment, which he may not have been able to demonstrate as well if they hadn't been involved. Another thing I was able to do is have some communication books as well as memory books built for individuals both in hospital as well as in the community, which was amazing. And luckily, because I was able to get some of those things done, which are often when your caseload is primarily swallowing, aren't necessarily demonstrated as well to management, that you have that ability to see communication in the adult population. Following having those students, I was actually able to show the need for those types of interventions, which I wasn't able to meet. And now I have a rehab assistant to support me in community. So sometimes seeing what we can do with help makes other people realize how much we're doing with so little.
Thank you so much, Kayla. Thank you for sharing those specific examples. Wow. And Colleen.
So on my unit, each discipline would rotate to do an patient education session. So I found that with students, and even other disciplines as well, we often involve our students to run those information sessions. Sometimes they end up getting rescheduled if like we're short staffed or caseload is busy, but when we have students, I noticed that we were able to do that more regularly. And I think it was also nice that there was two students at the time because I think they enjoyed doing it together because it can be a bit intimidating doing a presentation by yourself in front of a group of people. And I kind of similar along the lines with Kayla and Ivana, I felt like we were able to run groups more consistently as well. And what I really liked about having two students is that the group can be a little bit bigger. And when the two students were familiar with particular patients, they could be there to support the patients that they're most familiar with rather than just one therapist there and supporting like, 3+4, which is definitely more challenging.
Excellent. Thank you for sharing all of those new projects and innovations that you were able to implement because of having two students. I'm going to pause again just to see if there's any questions from our participants, from our attendees. If any of the previous questions thank you. Thank you, Joan. Hello, Joan. Can Ivana elaborate on co-treating two children at the same time? They are in the same room, but doing completely different sessions, or are they doing the activities together? Great question.
Such a great question, Joan, especially because physio does this differently. And so I'm playing around with the way that we do it in speech. The way that the physio student-led clinic at the BC Center for Ability has done this is they have this huge, massive gym. And so they can be in totally different corners of the gym. And I'm just kind of floating, or like the physio equivalent of me would be floating between the two kind of subgroups there. So they might be doing totally different activities. They might be at totally different physical levels or totally different skills. Now, for speech, the nice thing is we have the option to do that, where maybe we have a big, nice room with lots of toys and play areas, and two very different kids with very different profiles can be in that big room together. The other thing that I'm exploring as well to see how it goes is if we have two clients who are picked to be together based on similar goals. So two kids who are both working on switch access, or two kids who both love music and really respond to it. So I'm going to try and see which of the two works. The nice thing about having clients who have totally different profiles in the same room is that there's virtual technology that's available where families can book themselves in. So we're really making use of that to hopefully save time on my end so I can do a few more clinical things. But we've set it up such that there's like a platform through Microsoft on Booking where two families, doesn't matter what the child's profile is or goals are, can book in whenever. So it allows for that flexibility to save a bit of time in terms of setting that up. But to answer your question, Joan, it's a little bit of both. We're exploring both. Hopefully that answers your question. Let me know if that was clear.
Thank you. Okay. Are there any other questions? Please feel free to raise your hand, put your video on, pop them in the chat. I will continue with question number 8. How can the clinical educator make sure each student gets the most out of their placement? I'm going to change it up. Let's start with Kayla.
So with the students working together and really learning from each other and collaborating before they come to us, like I think, I don't know if I would ever an externship to not take 2 students again, because they worked so well together, sort of coming up with things, looking up things, having so much more independence earlier in their placement. That team model, in my opinion, took a lot of work off of my plate, because they could ask me a question as a group and I could say, well, you guys talk about it, come back to me with what you think. And they would come back with amazing ideas, like never far off, because they've really refined it. So I think that is how they get the most out of their placement for sure. And it supports my time management as well.
Thank you. Colleen, let's go to you next.
Yeah, similar to what Kayla was saying, I think like fostering that collaboration right off the bat, not just for their peer learning, but just also for like the nature of our work being so collaborative and interdisciplinary. So one thing that I noticed during my placement was, compared to my one student placements, was that when a question came up, I noticed that my students would often just actually talked with each other and then figure it out on their own and then move on. And only when they needed a bit more guidance and support, then they came to me. So it was really interesting to see the difference between a 2-to-1 placement versus 1-to-1 placement. That was something that I thought was really neat and interesting. And initially, I think maybe many of us who are new to the 2-to-1 placement, and I also had this too, I thought that taking 2 students would be a lot more work, but in that aspect, like what Kayla was saying, that really helped with my time management because they were able to problem solve themselves first before coming to me.
Thank you. And Ivana, if you have any other thoughts on that question, how do we make the most out of their placement?
Yeah, I think the fact that it's representative of the job, like what Colleen was saying, like you really do have to collaborate. So it allows for that collaboration, which can be a really rich, not just within the 2 students together, but also within a broader team, where you get to learn not just a little bit about speech or audiology or whatever it is, but also you get to work alongside an OT or alongside a PT. And so something really special at my placement that we got to set up was like a positioning consult, where my students got to learn about the positioning involved for feeding and for play for some of our children where head control is challenging. And so all of a sudden, that not only enhanced their knowledge of their clinical skills, but also the broader environment that they're working in. And so they got so much out of that. And then by the end of the placement, they were independently trying to figure out which positioning would be best for a client, whether hand access, manual access, or foot access would be good for AAC. Like it just became not just about the clinical skills that they were doing, but the bigger picture. And so they got quite a lot out of that, which was really incredible. The other thing, less clinical, is that we have this lunchroom at the Center for Ability, which is full of people and it can be quite intimidating. So it's kind of nice to have another student go in together and have people go in together so that they can sit at the lunch table and meet people. And so the expectation that I'm trying to set up is that we all eat lunch in the lunchroom, and it's a lot less scary when there's 2 of you. So they get to make social connections and talk about not just work, but also what life is like for clinicians who work at the center. And so it becomes very real what a job could look like at the center. So that's been really special as well.
Excellent. Thank you, everyone, for sharing. The next 2 questions are a bit more logistical, so me and Evan will answer the next 2. So this question, are students matched based on how well they work together or randomly paired? So there's a lot of factors, many different factors that go into the student matching when we go through the externship planning process. All of our students at both of our Vancouver and Victoria sites are used to group work and used to working in peers for projects, for presentations, for many of their assignments. And so, that's a given going into the externships. So they know of each other. They've probably worked in groups already, just based on how their assignments have gone, or presentations or projects. Because I've just taken the lead with externship 1 and 2, so I'll talk more to that. We try as an ACE team and whoever is taking the lead to ensure that the students have either preschool, a school age, and an adult population in their first 3 externships. So because externship 1 is April, May, most of the externship 1s, it's only a 5-week placement, are school districts. So then if we have a student, this is just an example, because it could be any combination of the 3 populations. So if externship 1 is a school district or a school age placement, externship 2 has to be a preschool or an adult placement, because we all know that school districts are not open in the summer. And then the students come back in the fall and it's a part-time placement, externship 3, where they're in classes 2 days a week, and then they're also in placement 2 days a week. And so whatever they haven't gotten yet, that's what we try really hard to match the placement for that specific student. So just to go back to my original example, it could be school district, adult, and then externship 3 would be preschool. Again, we try, because as we all know, we are at our, we need the offers, and we have the offers from our wonderful clinical community like yourselves. So whatever offers are on the table, we have to use those. So we let students know that we cannot turn down any of our placements or our offers because our clinical community is volunteering, and we're so grateful for their time and their efforts and their patience and their dedication to our clinical education program. So for that question, it's a little bit of both. We know that the students do work well together. It isn't randomly paired, but the population is a major factor in how the students are paired together. A lot of our students do ask to go out with peers, especially if they're going out to a rural placement or a rural location that they haven't been to before. They requested, I feel a little bit nervous about going to a rural place. Can I please go with another peer? So that's taken into consideration as well. Evan, is there anything that you would like to add to this question?
No, only just again, I think just echo the intentionality of it as best we can, considering the factors of what we know of the students as well, and how they will work together, and similarly what we know of the site. So it's not even just is a pediatric, they need pediatric, but we do take other parts of the site and what we know and the feedback we get from you to consider how that student will be best set up for success, right? Because that's ultimately what we want at the end of the day, is to have our students in the best learning environments that you guys are providing to them. So yeah, there's a lot of thought and a lot of factors that is also then balanced with we have 44 or 88 placements and we need 88 offers. And so how do we make this work? Which I think is another sort of exciting change to the offers that we're getting from you, is that people are looking for more 2-on-1, are looking for more group supervision ideas, models, and are willing to try it. And I think that bodes really well for our matching process as well.
Thank you. All right. Another sort of logistical question. How can the CE ensure that both students have enough client time for adequate feedback and assessment of their clinical skills? Then do you want to take this one first, or do you want me to?
You go ahead, because I'm actually making notes as we go, so that there might be a bit of something at the end of this.
Okay, thank you. Thank you for doing that. Yeah, so I would like to just remind all the clinical educators that there are no minimum requirements for hours for any of our externships. So externship 1 does not have any minimal hours. Externship 4 does not have any minimum hours. We also tell the students this in our Audi 545 at our externship prep class, but sometimes, as we know, students can be a little bit anxious about hours. But it's not the CE's responsibility to keep track of the students' hours or to ensure that they have, a certain amount of voice hours or a certain amount of AAC hours. That's not on the clinical educator at all. That's a responsibility of the student. And we go through what counts as a clinical hour, what doesn't. And we will actually be teaching that to the students in about 2 weeks. So there's a huge range in the hours that the students will receive and obtain for any one externship. It depends, of course, on the population that you're working with, how busy your clinical workday is, how many clients you see a day, how many cancellations you get per day or per week. Those are all just part of, a typical work day or work week. And we try to explain that to the students, not to get so hung up on hours. Our students will graduate with the requirements that they need for clinical hours. Usually they graduate with more than what is needed. So we also tell them that. What can count as a clinical hours? Any one-on-one time that the students spend with a client, but also observation. So if we go back to what our panels have mentioned about a lead student and an observer student, the observer student can count those clinical hours as well, because they're observing. There maybe they're doing a behavioral checklist, maybe they're doing a speech sample, maybe they're doing a language sample, maybe they're taking notes. So any sort of active participation, active observation, they can count those same hours. If there's any discussion about a client with the clinical educator or with the student, with the other student, they can count those hours. So rounds, parent meetings, IEP meetings, school-based team meetings, all those hours can count if they're talking about a client. After an assessment, and if you're discussing the interpretation of the assessment results about the client with the students, or if the students are talking about that as well, they can count those hours. What can't count is any charting, any progress note writing, and any assessment report writing. But just to reiterate, they will have more than enough hours than they need to graduate the program. Amanda, did you want to add anything?
No, I think that covers it. I think the best experience they can have is to see what your day looks like, what your caseload looks like, what your working week looks like. And so that's what they're there to learn, not to just count the 15-minute increments. Yes, it's important, but I think that's one of the wonderful reasons that the requirements is no longer there. It does take that pressure off. And so I think just that they get to be in your space and learning from you, that's the most important part.
Exactly. All right, this is our last formal question. But again, if you have any questions, please raise your hand. Please pop them in the chat. Oh, clinical feedback. Joan, let's get to that first. I imagine it is a mix of joint feedback and individual feedback to the students, but the midterms and final eval need to be individual. I didn't want to assume though. Does any one of our panelists want to take that question?
That's how I've been doing it. I'm not totally sure what the expectation is, but that's how I've been doing it. The feedback can be a mix, but the evaluation is really a single student's evaluation for what their skills are moving forward and what areas of practice need to be addressed. So
That's how I approached it as well.
And I would say from the school's perspective, that's probably what we would advise, that midterm and final, because it's more formal than just regular feedback, that it is good to do it in a one-on-one. However, from my experience doing it, rarely has there ever been anything that's been a surprise that's needed to be discussed at midterm and final. And that's because, as has already been discussed, there likely will already be a balance between one-on-one and group meetings for feedback anyway. But as the students become more comfortable with one another, they become more and more comfortable with these things being shared in a group. So even if a group is sort of what you've done, especially as it's getting towards the final, oftentimes I think they'll know what's coming even for each other, as that sort of collaborative learning environment continues to grow.
Thanks, Amanda. Okay. And this is our last formal question, like I mentioned. How does a clinical educator manage limited space? Example, a small office. And all of us are going to answer. So Ivana, you want to start, please?
yeah, sometimes we have access to a big room, but in some student blocks, we've only had like one small clinic space, so we've had to get creative. For pediatrics, sometimes it's actually useful to have a couple extra hands in the room in case things need to be moved, or you need to grab something from a different space in the office. So sometimes having a couple extra hands in the room can actually be really helpful, not just if the student is observing, but maybe if something happens. Also, having one student sit in front of the door and then the other student works with the student is really useful for some of our kids who love to run. And our clinic is big with some hazards, so we like to make sure that it's a safe, secure space. The other thing that we've made really good use of is virtual parent coaching sessions. So more and more evidence is coming out about how parent coaching virtually can be really meaningful. So we'll have families set up a camera in their home space and practice having the student coach the parent through language strategies. And that's been really, really cool to help families who actually prefer the virtual modality. And it kind of solves the space question, obviously not for the duration of the placement, but if you're sharing a space or the space is small, it might be a nice way to expand out a bit. The other nice thing too is if a student is sick, because in pediatrics that super happens. And so we'll have one student who's feeling well in the room, and then we might set up, if the parent consents, a virtual camera so that through Microsoft Teams or whatever platform we're using for a hybrid model, the other student can observe. And so they're still getting some of that time in.
Excellent, thank you. Kayla, do you want to add anything about the small space?
Sure. So I don't have much space. I'm based out of a hospital. So the students kind of work off the side of my desk. And when we actually see our clients, it can be like up on an inpatient unit. It can be at a dining room table in their home. It can be just about anywhere. So a lot of the sort of collaborative and prep work we did we would do kind of together in my tiny little space. But I also had the students do some of it together in advance. Like they were sharing accommodation when they were living up here. So they would maybe come in at 10 o'clock that day and do a bunch of their planning to not disrupt like coworkers prior. So they would do some of that, or sometimes they would leave a little bit earlier in the day to be able to kind of do some of that prep work for the next day, kind of from a working at home type model when it was appropriate. And it really did help sort of take off the demands of having 3 people in a very tiny spot that also has additional other allied health staff. So it worked quite well, especially because they were living together, because that was a private environment. They could actually talk about patient care things because they couldn't necessarily go to another spot in the hospital unless it was confidential.
Great, thank you so much. Colleen, anything to add about small spaces?
Space-wise, here we were actually okay, but maybe our main problem sometimes was that we didn't have enough computers. So we did have access to laptops that the students were able to use, but if we did run into an issue where other students were on site from other disciplines and laptops were not always available, then I would try to stagger the charting times and treatment times. Like one student would do treatment and another student would be charting, or sometimes I might have them work on a chart note or like assessment report together.
Excellent, all great. Thank you so much. So this is sort of the end of all of our formal questions. We did get through a lot. Are there any final questions from our participants, from the attendees? Before we move on, there's a few slides that I would like to share. We did ask some students for their perspective, and I would like to share Stephanie Core's audiology perspective. But first, let me see if there's any final questions from our people that are here.
Another question from Joan, just around the first placement. How many clinical feedback sessions each week would be ideal?
Hmm.
Kayla, Colleen, or Ivana, do you want to jump in? Do you want Cheryl and I to jump in?
I haven't done externship one yet, so I'm not sure about.
TBD. So Joan, so besides the informal feedback, so do you mean when you say how many clinical feedback sessions, as in sitting down with them quite, I guess the informal feedback part has thrown me. How do you mean? If you don't
Sorry, I'm eating my lunch at the same
No
time.
worries. I'm putting you on the spot. I'm sorry.
I guess I'm trying, like, this is my first time, and so I'm just sort of trying to picture a schedule that's realistic. And by, how many clients, and then also trying to figure out, it sounds like, if we have time, we probably would give feedback fairly immediately if we can, but there might be that bigger picture feedback on that touches on all the clients, like how are what's something a skill they need to be working on, or where do they need more direction. And like, I know, yeah, the first placement, there's a lot more feedback and a lot more learning that's still happening. Um, but yeah, just trying to structure my week to make sure that we're not overbooking with clients, but giving enough time for feedback, and also that it's realistic for our busy caseloads.
Sure. Yeah, I like I think it was Colleen had mentioned it, forgive me if I'm wrong, but about doing sort of a meeting at the beginning of the week, sort of this is what the week's going to look like, these are the clients, this is what we're sort of set up, and then a meeting at the end of the week where maybe if you're given that written feedback and you don't always get to it, that sort of can tie up those loose ends. Maybe it's sort of, to your point, Joan, that more overview of looking at the entire caseload versus just sort of specific individual pieces. So I think if that's at all manageable, I think that is helpful. I think if you could only do one or the other, I'd be leaning towards maybe the end of the week, because at the end of the week you can still sort of prep for the following week or have an idea around the following week. But I don't think it has to be excessive by any stretch of the imagination, especially if they're getting, there's a lot to be said for that informal feedback that they get on the fly. And if that can be sort of given in some sort of shorthand as well that they can hold on to and maybe even go away and think about and reflect on and come back and ask you. Often that's actually really helpful, that they're not sort of expected to respond to the feedback straight away. Sometimes, especially an externship one, they kind of need to know what to do with it. So I hope that answers the question somewhat. And Cheryl or Kayla, Colleen, even if I've said anything that resonates or anything wrong, let me know.
And just to acknowledge that we know that externship one is, only 5 weeks. So I think take these ideas as guidelines, and then, you can work with the students and possibly tweak things and modify things as you continue with that externship. But it is a short one, we know that. But thank you, Joan, for taking 2 students. So this is from Stephanie Kaur. She's our audiologist because she has been working at the UBC Audiology in-house clinic. I think we just have SLP, clinical educators, here right now, so I won't read this out loud, but she has some really wonderful ideas about how she's taken her experiences with the in-house clinic at the Friedman building and extrapolating how it could work for an audiologist in their clinical setting to take 2 students. And she's put lots of time and effort into this. And again, I have a full 2-page document that will be shared on our virtual community of practice under events, where the PowerPoint will be and where the video recording of this lecture will be, or session will be. So thank you, Stephanie. So we asked some of our students, if this is not working, doesn't seem to be working. Of course, there we go. So we asked some of our students who have gone on 2-on-1 placements, group placements, about their experiences with this type of model. I really like this one because I think I had mentioned it before. Because I had little prior experience working with adults, the 2-on-1 helped me feel more comfortable entering a new clinical population. And having a peer alongside me reduced anxiety and increased my confidence. Moving out of town for a placement can be isolating, and having a classmate there provided meaningful personal support. Sharing the experience positively impacted my well-being and reduced feelings of loneliness. Although we were not particularly close before the placement, living and learning together strengthened our relationship, and we have since become close friends. So I thought that was a lovely quote to start off our student segment. I'm not going to read these out loud. I know there's a lot, but our students really enjoy the 2-on-1 placement. They really get used to the peer-assisted learning. I think, as Evan mentioned before, sometimes they can be reticent about it and nervous about it and receiving and giving feedback to each other. But as the placements continue, they just get used to it and it just becomes part of their everyday routine and everyday schedule. This one talks about the lead student and then the observer student. And then this one talks about learning and collaboration. So these will be on our virtual community of practice. I won't read them out loud for you because I know that you can all read. And there's a few things that we still need to do with our 5 minutes left. Oh, sorry, there's one thing. The very last sentence here I found quite resonated with me. For example, my peer and I had different presentation styles, and working together effectively required flexibility from the both of us. So this goes back to what Ivana had mentioned before about the students. It's required of our students to work on healthcare professional teams and to collaborate and to work with others. So I thought that last sentence really highlighted that. All right, any final questions before we sign off for today? If you have any, please feel free to put them in the chat. You can also feel free to reach out to Ivan or I, and our emails are at the end. So thank you everyone for attending. Clint Myers, our administrative person who handles all the money, is giving one lucky person a $25 gift certificate to Amazon for attending today. And Jamie, do you want to announce the winner? This one is based on random selection.
Yes. So our randomly selected winner for this prize is Joan Beek.
Wonderful.
Yeah.
Thank you, Jamie.
So Joan will be in touch with how to get that delivered to you. It should be electronic though.
And thank you, Jamie. And thank you, Clint. I always ask for money and he usually gives it to me. So here's on the ACE team. This is our wonderful team. Marcia Choi is the lead of our team. That's her email. Lisa left, myself, Evan, Kate. Kate is our site lead at the Victoria program, and she's also a member of our ACE team. For audiology, it's Sasha and Darlene. One thing that might not have been made clear is that each of our students are followed by one specific ACE member or clinical coordinator, and we follow the students for their whole 2 years throughout their program. So for every externship that they go on, I have 9 students, Evan has 9 students for first years, and then we also have 9 students or 10 students for second years. So we get to know them quite well, and we have really we establish really close relationships with our clinical educators. If there are any questions or concerns about the placement, about the student, please feel free to reach out to your assigned ACE member as soon as possible. We are very responsive to emails, especially when it gets to externship time. Also, to the externship schedules for externship 1 and 2 will hopefully be emailed out within the next 2 weeks. So when you receive that email, you will know in that email who your assigned ACE person is, along with your student. The student and the clinical educators get those emails of the externship schedules at the exact same time. Jamie and Bailey are also part of our team, so that's an error on my part. But Jamie Nagy, who is here, she's our senior clinical program assistant at Point Grey, and Bailey is our program administrator at Victoria. They are integral to even having placements and to even making the clinical education program possible at UBC. They've been working really, really hard behind the scenes for externship 4, 1, and 2 to get all the details finalized. Many emails have been sent in the past few months. So a huge thank you to Jamie and Bailey for all you do for our program and for this school. We really could not do this without your work and your help and your support. Valerie, the executive assistant to the director, helped us with the social media and announcing these sessions on our social media. So thank you to Valerie. And of course, thank you to Clint for supporting our endeavors and giving a little tidbits of prizes for the people that attended. There's some additional resources there on the 2-on-1 model, and those will be posted on our VCOP, like I said. I'd really like to end with thanking everybody who attended today for taking time out of your schedules to be with us, for your questions, for your attendance, but ultimately, thank you for taking our students. We also could not have our clinical education program without you. So we are grateful. The school is grateful. A huge, huge thank you to Colleen, Eva, and Kayla for being our panelists today. sharing just wonderful tidbits and of information, your experience. I think, Evan, you have said this before, but if you've taken 2 students again, we're so happy and thankful that you're going to take 2 students again for another rotation. I think Evan said it better, but yeah, just a huge thank you to the panelists. Evan, who am I missing? I always miss someone.
No, I don't think you did. I think you did really well.
Okay.
So just a big thank you. And yeah, I see people are needing to
Yeah.
log off, which is perfectly fine.
Yeah.
Jamie, whenever you want to stop the recording, I don't know if you've done that already, but you can do that.